Obesity, whenever we are talking about obesity, three things usually in general domain, three things come in mind. One is weight loss to an individual who is otherwise normal weight for various professional and pressure reasons actually. Second is the weight loss of the individuals who are marginally overweight, again because of two reasons, either because of their professional reason or because now they are aware that if they don't take care of themselves now, they will turn up to be obese tomorrow, and therefore, and they have not yet developed any comorbidity or any complication in terms of metabolic illnesses or systemic illnesses, and they really want to do the weight loss for the as a preventive measure. Group 2. Group 3 is the one who are actually moderate to severe overweight, or they are obese people. They either have the comorbidities or they yet not have the comorbidities, and they are looking for the management of obesity. Clear? So 3. Now the question is, who out of them need more of the medical attention and who can be handled by simply changing the lifestyle in terms of the dietary modifications or in terms of the exercise or the combination of that, and without needing much of the medication. So the people, group 1, who are otherwise normal weight, but because of whatever the pressure they have in terms of the professional commitments, in terms of the professional demand, in terms of going for some interview where there are some benchmarks what they have to fulfill even for appearing for the interview, like the cabin crew, like the models, like somebody walking on the ramp, like in army, like in police. Everywhere there is a standard that you cannot be more than X weight. And then they have to, or maybe the sports people, maybe the athletes and all. Again today there is a same story in the Times of India. So athletes, sports people, and the glamour world, the media world, the army people, the police people, defense people and all, they are the one who may be at the normal weight, and still for that particular criteria they have to reach to a weight to fulfill that criteria. There is nothing to do with health over there. The people who are, so there we have to, so what are we going to do over there? There we are going to simply, change their or modify their lifestyle to a certain extent, which actually they know by themselves. We just motivate them a bit more. We simply give them some calorie restriction. We just motivate them to leave few things what they are doing. And the best way of calorie restriction to be advised to anybody is, our first step is to tell them to not to eat anything which is not cooked at home. I think that is the easiest thing what anybody can do, anybody does, right? Because as soon as we stop eating things which are not cooked at home, and when I say that, not eating anything, at least for that duration, till you are fulfilling your target. I am talking about again group A. It decreases the calories very significantly. So a biscuit, a cookie which is there in front of us, they are very rich in calories. Secondly, is even the food what anybody is eating in a restaurant or in a hotel is not the one what they can control. So anybody else cooking food for you, you cannot control that food, even if that is a cook at your home, right? Because the cook will also make the food as per his or her expertise, and one thing cook will never want to do, compromise on the taste. And Indians can, or human beings can taste fat. Human beings do crave for fat. Human beings do crave for carbohydrate. Okay? So the only thing what we tell them is, stop eating outside, increase your exercise timing, your exercise intensity, and most of the time without any medical management they reach to their target because they are very motivated, and the biggest motivation in them is their career. Now the people who are say 2, 3, 4, 5 kg overweight now, and there, or maybe a bit more, so they are mild overweight, where again for two reasons they are coming to any weight management consultant, either a medical or a non-medical. One reason is that too much of talk about obesity every day in the media. then their family history of whatever complications of obesity, or the discussions at home and everywhere, and more than that, again the peer pressure. Okay, he is fit, I don't look fit. That pressure. Because of that, again they come in. For them, what again we can offer is, so here investigation plays the role. So in group 1, you are not going for much of the in-depth investigation, because they were otherwise fit. And again remember, they are the people who are from the younger age group, right? Now here, who are marginally overweight, one thing we understand is that the lipogenesis is increased in them. Lipogenesis is more than lipolysis in them. So other than the calorie excess, there is also the thing which the changes in the body which is going more in favor of the lipogenesis. That means the adaptations are happening. Some or the other changes might have happened in the body, and here comes the role of our biochemical and imaging, biochemical investigations and imaging. And here you are now looking for to identify whether they are pre-diabetic, whether their lipid profile is abnormal, whether their HbA1c is high, whether they have any subclinical endocrine issues. So if we are hitting at this level where people are marginally overweight, we can identify the impending abnormalities which are bound to come later on, or which are more chances to come later on. So we identify the marginal hypertensions over here, we identify subclinical cardiac cases here, we identify subclinical endocrine cases over here, like hypoandrogenism we find here, high estrogen, both men and women we find here, we find the subclinical thyroid cases over here. So our investigations become more intensive in terms of identifying some hidden reason in them, and something what we can modify tomorrow, right? So group A, investigations were not too many. Group B, it becomes more of investigation. But what about the intervention part? Because they were marginally overweight, our intervention still becomes more toward the calorie restriction and increasing the physical activity, and whatever we have found in the in our investigations, we are managing that, right? Then comes the third group. The third group is the typical obese who are moderately or severely overweight. Now this is the group where we know that complications have already set in. There are, whether they are manifesting or not, they are there inside the body. Lot of metabolic and endocrine and systemic derangements have already happened. Now here our investigations are extensive, because here we are now looking for the complications which have already happened, complications which are impending, metabolic derangements, endocrine derangements, all of these things, and then more than that is the mechanical derangements. Now here we are talking about osteoarthritis, here we are talking about arthritis, we are talking, and the mood disorders and all those things. So our investigations become more vast, supervision become more vast, and these are the group of people which will not respond simply to your dietary modifications and increasing the exercise. They are the people who will be looking definitely for the pharmacotherapy, either the pharmacotherapy or the surgery or the combination of both. तो हम बहुत क्लियर हो गए कि जो जैसे कि हमने हार्मोन्स के टाइम बात किया था कि 45 के नीचे है तो हम लोग दौड़ नहीं रहे, वी आर नॉट रनिंग बिहाइंड टू पुट देम ऑन HRT राइट अवे, वी आर ट्राइंग टू डू समथिंग सो दैट दे कैन इंड्यूस देयर ओन हार्मोन्स, राइट? हेयर ऑल्सो वी आर क्लियर दैट जो अदरवाइज हेल्दी है, हम सीधा दवाइयों के पीछे नहीं भागेंगे, वी आर नॉट रनिंग बिहाइंड फार्माकोथेरेपी इन दैट. जो मार्जिनली ओवरवेट है, वी मे नॉट रन फॉर द ओबेसिटी मेडिसिन इन दैम, we will be taking care of other abnormalities which might have happened, and calorie restriction with exercise become our mainstay of therapy. और अगर ये obesity हो गया और obese diabetes हो गया, there comes the role of all three of them. तो success mantra of all the dietitians who are managing weight or who are doing weight loss, not the obesity management, is only one. सबसे पहला मंत्रा यही है कि बाहर का खाना बंद करो. और ये इनडायरेक्ट है कि भाई आप बाहर नहीं खाएंगे तो आपका कैलोरी रिस्ट्रिक्शन ऑटोमेटिकली हो जाएगा, और बाहर खाना खाने बंद करने का मतलब है आपका कार्बोहाइड्रेट रिस्ट्रिक्ट हो गया, आपका ट्रांस फैट रिस्ट्रिक्ट हो गया. क्लियर? अब हम एक कदम आगे बढ़ते हैं कि नाउ जब हम डाइटरी रिस्ट्रिक्शन की बात करते हैं, नाउ वी आर डॉक्टर्स, तो डेफिनेटली वी हैव टू हैव सम साइंटिफिक वैलिडेशन ऑफ व्हाट एवर वी आर सेइंग. तो वी अगेन गो बैक। तो एक बार कहते हैं ना उसको क्या, क्रैश कोर्स कर लेते हैं जल्दी से फिर से। Obesity, whenever we are talking about obesity, three things usually. So now again we go back. जैसे we are talking about calorie restriction, हमने बोला किसी को भी okay, you should now restrict your diet, तो right away come, अच्छा let me do keto diet, वो डिटेल में चला जाता है, राइट। अच्छा मैं कीटो डाइट कर लेती हूँ या मैं कीटो डाइट कर लेता हूँ, या कोई उसको बोलेगा कि वाई डोंट यू डू कीटो डाइट, और वो इंटरनेट पे जाएंगे एंड दे विल सी कीटो डाइट। सो आंसर इज वेरी क्लियर, एवरी कैलोरी रिस्ट्रिक्टेड डाइट इज अ कीटो डाइट। हम बहुत क्लियर हो गए, राइट। एंड देन द नेक्स्ट थिंग विल कम that ketones come only from the fat diet. So we know that no, ketones don't come only from the fat diet. Anytime you are starving yourself or near starvation, or there is calorie deficit state of the body is, all the metabolic fuel of the body will start giving you the ketones. It's not necessarily that you have to be only on the fat diet to have the ketones. The basic principle still remain is that any low calorie diet or a very low calorie diet over a period of time is going to give ketogenesis. Then they will say that, no, we are not talking about the body ketones, the ketones made by the body. We are saying the ketones will be provided by the diet. No, that is the things what we always used to argue. ये चलता है जब if you really start doing the obesity practice like that way or weight loss, you will find all this, internet पर और जो बाकी के, अरे when are we saying that it should be the body ketones? Then the answer comes is, what do you mean to say? You are consuming ketones from outside? No, you are, end of the day, your body has to do its own job to generate ketones from either fat or the carbohydrate or the protein, right? So end of the day, it is going to be ketogenicity. Whether you are calling is a keto diet or you are calling is a ketotic diet, doesn't matter. It is end of the day a ketogenic diet only. Now, when we talk about the low calorie diet for a long time, which is going to be ketogenic in itself, or we say that every calorie restricted diet is a keto diet, then we have to understand that what would be the good, bad and ugly aspect of any keto diet and in terms of any calorie restricted diet for a long time. Now, when somebody, so as soon as we say that okay, it has to be a low calorie diet, then the question comes is, what is the main fundamental behind it? Obesity, whenever we are talking about obesity, three things usually, to give a low calorie diet and what is the pathway of losing the weight in that. Very, very clear. We are keeping one principle in our mind, कि whatever the restriction we are giving, one thing we are restricting to a significant level, that is our glucose. Glucose is one which we are restricting to a significant level. This is what we all have come to a consensus in today's world. If we can restrict glucose, probably our output will be very, very good. Now, to what extent of glucose we are restricting, that is very subjective. That is between the clinician and the patient, depending upon again the background of the patient, the religion of the patient, the ethnicity of the patient, the cultural beliefs of the patient. Many times, you cannot make anybody zero carbohydrate. Not many times. In India, it is impossible to make everybody zero carbohydrate because we are predominantly vegetarians, and vegetarian diet with zero carbohydrate is almost impossible. Okay. Now, but okay, we keep this. If the carbohydrate we can manage up till 20 grams a day, say up till 50 grams a day, we can still reach to a level of ketogenicity in the body at certain point of time. May not be in day 3 or day 4, but maybe a bit later. Those 40 days of thing what we had discussed yesterday on starvation, that will be delayed, but that will happen. Now, what is the basic principle about it? That we have glycogen in our body. How much glycogen we have? We have 75 grams of glycogen in the liver, and we have almost about say 250 to 350 grams of glycogen in our muscle. So 75 grams of glycogen, this is our target to exhaust initially. We have to exhaust the source of glucose, direct source of glucose from the body, which is glycogen. उसको हमको ख़त्म करना है, उसको हमको exhaust करना है completely. So 75 grams of glycogen can give you 300 calories. Very simple. And muscle glycogen also convert into glucose, and muscle glycogen converts in pyruvate, but somehow the muscle glycogen is not directly involved in increasing the blood glucose level or supplying the glucose initially to the blood. But the same pyruvate, when converts to alanine, one of the amino acid, that alanine goes to the liver, and there again it can go in the gluconeogenesis and can give the glucose. So indirectly even that 300 grams can be used. So 300 grams and 75 grams, so almost 400 grams of glycogen can be consumed, which can give almost about 1600 calories. So point number one, when you are putting anybody on a dietary restriction, ask the patient to do at least 1 or 2 days of complete water fasting, if possible, or as much as fluid possible. So no carbohydrate for at least next 2 days. So 2 days किया तो क्या हो गया? Glycogen gone, glucose of the body gone. Now we remember one thing. वो पूरा का पूरा अब याद रखिएगा. That chart, you remember that chart? 40 days. अब हम आ जाते हैं कि भाई 2 दिन के बाद क्या होगा? 2 दिन के बाद सबसे important, in these 2 days ghrelin will come down, ghrelin will start coming up because glucose is going down. Not, and glucose पूरा जाता नहीं है क्योंकि ग्लाइकोजिनोलाइसिस हो रहा है, थोड़ा सा ग्लूकोनियोजेनेसिस फ्रॉम द प्रोटीन भी हो रहा है, तो ग्लूकोज स्टिल देयर. सो थर्ड डे ऑल्सो यू आर नॉट एडिंग अप ग्लूकोज, आप रिस्ट्रिक्टेड ही रख रहे हैं थर्ड डे पर भी. नाउ द ग्रेलिन which will go up because of the fluctuation of glucose is going to tell the brain go and eat, right? Because glucose is going down. Brain will say that okay, glucose is going down, I have to increase the glucose, and there is a time when the counter regulatory hormones will start coming up in a good amount. Initially also it is coming, day 1 also it is coming, otherwise glycogenolysis will also not happen. But now gluconeogenesis has to be at a higher rate, and even the lipolysis has to set in. GH will come in, catecholamines are already there inside, glucagon is already there, TSH start going up, ACTH is, because now it's a stress also to the body. Not giving the food to the body is a stress. So it is going to respond like a stress phenomenon. So ACTH will go up, MSH will go up, and body will start looking for the food. And this is the time when the patient is calling you and telling you, डॉक्टर नहीं हो रहा है. कितना भी अच्छा डिफेंस मैकेनिज्म क्यों ना हो उसका, तो ऑलमोस्ट 50% लोगों में तो डिफेंस मैकेनिज्म पूरा ब्लंट हो चुका है. वो वापस आने में ही टाइम लगता है, बिकॉज लाइफ लॉन्ग दे हैव नेवर एवर experienced fasting in their whole life, right? Now for the very first time they are doing it. और पहले जो भी फास्टिंग की कभी भी किया तो रिलीजियस की वजह से किया या कुछ भी अपने मन से किया, यहाँ हो रहा है डॉक्टर के कहने पर कर रहे हैं, तो बड़ा मुश्किल हो जाता है वैसे भी. Then so here your patient needs you. There you are explaining, don't worry, nothing would happen. Hey, I am getting headache. Now why the patient is getting headache? Because brain is looking for all the possible glucose available. ब्रेन को अपना 120 ग्राम ग्लूकोज चाहिए, ग्लूकोज लेकिन अभी ब्लड में कम है क्योंकि जीआई ट्रैक से ग्लूकोज नहीं आ रहा है. कम का मतलब है लिमिटेड है. सो मसल स्टॉप यूजिंग ग्लूकोज, लिवर स्टॉप यूजिंग ग्लूकोज, किडनी स्टॉप यूजिंग ग्लूकोज एक्सेप्ट फॉर द रीनल मेडुला, स्प्लीन, ऑल द अदर ऑर्गन्स आर कंप्रोमाइजिंग ऑन द यूटिलाइजेशन ऑफ ग्लूकोज कि ग्लूकोज थोड़ा स्पेयर हो जाए ब्लड के अंदर. लेकिन अब वो ब्लड तेजी से जाता है ब्रेन में टू डिलीवर द ग्लूकोज एट अ फास्टर रेट. Got it? And because of that they start getting headache. This is nothing but, you can say migraine or you can say hunger induced migraine. Clear? This you tell patient कि don't worry, headache हो रहा है, take a painkiller. Painkillers are not always bad. So take a very simple paracetamol, take a, or even a migraine medication for that one day. You can give a Vasograin or anything to that patient on that particular day. कि my target is also to decrease the size of your stomach. That is also my target. In 40 days, I will decrease the, not the size of stomach, I will decrease the holding capacity of your stomach. Like you do during pregnancy, uterus grows like this. Involution takes how much time, madam? 40 days. There is involution. In 40 days, uterus again becomes a pelvic organ. 40 days it takes. For uterus, इतना बड़ा होने के बाद में 40 दिन में वो रिग्रेस होकर के इन्वॉल्यूट होकर के आ जाता है। अब सोचिए, नाउ थिंक अबाउट यूट्रस एंड थिंक अबाउट स्टमक, एंड देयरफॉर वी आर डॉक्टर्स। गॉट इट? हमको उसी स्टमक की होल्डिंग कैपेसिटी को वापस हमको लेके आना है कि अब ये 50 ग्राम खाने में सेटिस्फाई हो जाए। दिस इज स्टमक साइज, राइट? कैन यू बिलीव दैट दिस स्टमक कैन हैव लीटर्स ऑफ फ्लूइड? गॉट इट? तो इसीलिए अब ये हमको समझाना है डे 1 पर कि ये टारगेट है, तकलीफ होगी, लेकिन हमको, मैं हूं तुम्हारे साथ, आई एम विद यू, डोंट वरी अबाउट इट। इफ दे आर विजिलेंट एनफ, सो नाउ इफ दे आर विजिलेंट एनफ and if you feel that there can be a problem, let them keep a glucometer, and there is always some assistance in the family. If there is an issue, they can check the glucose. More, I am telling you, you will not find otherwise healthy individual having hypoglycemia just like that. Symptoms are there, but people feel it is hypoglycemia, but it is actually not hypoglycemia. But again, when we are managing, we have to keep all those complications in our mind, and we should be able to tackle them. Abhi, see, in medical management, nothing can be just like a cakewalk. And we are doctors, we also don't want anything to be a cakewalk. Right? What is the difference between the internet doctors and you? Okay? But usually doesn't happen, because body will not let the hypoglycemia happen. And that's why the defense mechanisms are there, na? Fine. Obesity, whenever we are talking about obesity, three things usually. Now what is the pathway which is happening inside? So there is a limited glucose, so brain is asking for the glucose. Now GI tract is not giving enough glucose. Brain says that I want glucose. Their RBC says that I cannot handle without glucose, I cannot even use any other fuel. All the other body organs they start using the fatty acid, they start using the amino acid. Okay? After few days, maybe 1 week time, from 120 grams of glucose, the brain starts saying that I am okay using 80 grams of glucose. So the other 40 gram can start coming from the ketone bodies. Fine. And RBC still are dependent on the glucose. Again, glucose is not going in. Other food items are going in a very restricted way. So calories are restricted, glucose is also restricted. On subsequent days, the brain compromises more on the glucose utilization, and brain says that okay, I am comfortable with the ketones, so give me ketones or keep giving me ketones. Body says that okay, I'll give you the fatty acid because I have enough stores of triglyceride in my body, in the adipose side, which I have been breaking for last so many days. So why don't you start using triglyceride? Brain says that triglyceride cannot enter in me because of the barrier. So liver, why don't you just keep sending me the ketones? So liver takes all the responsibility of ketogenesis or fatty acid oxidation. Liver breaks down the with the fatty acid oxidation, liver gets its own energy because liver cannot use the ketones by itself. Okay, and the ketones are released in the blood, and the ketones go to the brain, and brain is comfortable. Okay, I am utilizing ketones, but still I want 30 grams of glucose finally. So that 30 gram of glucose either you are giving from the diet, or means the food what you are giving, or the body is not getting any glucose or much of the glucose. So some or the other glucose should come from the gluconeogenesis. Now this gluconeogenesis is happening from where? Initially it was happening from the glycerol, which was coming from the breakdown of the triglyceride, which is fatty acid and glycerol. So this glycerol was going in gluconeogenesis. Initially, in initial few days of your calorie restriction, this is just giving 10% of the glucose, or it is involved 10%. And initially because the proteins are abundantly available, freely available in your muscle and all. So initially the protein of the muscle start breaking down. I am talking about the initial few days of the calorie restriction. क्योंकि मुझे starvation से थोड़ा आगे जाना है. I am not talking about starvation, because starvation is not what we are going to do. Fine. Now if you are doing the water only diet or something, that is a different thing. Now if we are when the protein start breaking down, there will be amino acids, and few of the amino acids are gluconeogenic. Right? What are the amino acids which are gluconeogenic? We had already discussed yesterday. So again, we can enumerate them. So methionine, threonine, phenylalanine, tryptophan, valine, histidine, isoleucine, arginine, alanine, aspartate, glutamine, glutamate, hydroxyproline, maybe glycine, tyrosine. So they all are the gluconeogenic amino acid, and they can also enter directly in the, and they are neogenic and also can give the energy through the TCA cycle. And TCA cycle is actually the core cycle for anything. For anything to give energy, finally it is the TCA cycle. Whether it is glucose, so NADH, FAD and everything which is formed, then finally go to the electron transport and then gives the energy. But this is the connecting between the glucose, protein and fat, and through which acetyl-CoA. So acetyl-CoA is important. Acetyl-CoA is coming from all of them. It is coming from protein, coming from fat, coming from the glucose. And this acetyl-CoA is entering in the TCA cycle, and finally the energy is being given. This is what मोटे मोटे तौर पर हम सबने कल समझ लिया था और आज हमको याद रखना है. Now when this protein start breaking down, amino acids are coming, the gluconeogenic amino acids are giving glucose, and the other glucose is coming from the glycerol. But after a few days, again, protein is something what body cannot compromise on, otherwise it will break down. So to prevent that protein, so इसीलिए in initial days, even give the restriction of protein. Now this is also important. So you have given carbohydrate restriction. Now in initial, say 3-4 days, you give even protein at a lesser rate. Don't give too much of protein. Why? You want to create an artificial situation of protein deficiency. So you created artificial situation of glucose deficiency. Glycogen खत्म, glucose खत्म मतलब glucose कम, ब्रेन जिद्दी, ब्रेन को चाहिए ग्लूकोज, आरबीसी को चाहिए ग्लूकोज. उन्होंने कहा वी वांट ग्लूकोज, ईदर गिव फ्रॉम आउटसाइड और गिव फ्रॉम इनसाइड, वी डोंट केयर. आउटसाइड वी आर नॉट प्रोवाइडिंग, इनसाइड इट इज कमिंग फ्रॉम द प्रोटीन. नाउ अगेन अ डिफेंस विल कम, प्रोटीन वी कांट ब्रेक, right? But if we are giving enough protein from outside initial days, then it is okay na. Protein will keep on breaking. We are giving protein, the fat will not break. So initial days again we are giving some protein deficiency also. So we are not providing too much of protein. So we are giving 10 grams, 20 grams of protein. So it is a typical calorie restricted diet. Again, it is a low carbohydrate, it is very low fat, and it is a low protein. Got it? Now you have induced that situation कि प्रोटीन मसल का ब्रेक डाउन होना नहीं चाहिए, नेचर ने बोला, और बाहर से आप ज़्यादा दे नहीं रहे हैं, राइट? व्हाट वुड हैपन? बॉडी हैज़ टू गो इन द डिफेंस मैकेनिज्म ऑफ प्रिवेंटिंग द प्रोटीन, एंड व्हाट वी हैव सीन यस्टरडे, आफ्टर फ्यू डेज द नाइट्रोजन in the urine start going down. Okay? And why? How does it happen? But then the body says that I cannot compromise more on the protein. Now the fat, you start breaking down. Now it's your turn to start breaking down dominantly, and then the lipolysis starts setting up. Got it? So the initial weight loss what anybody is getting is the loss of glycogen, and yesterday we have spoken that 1 gram of glycogen will have 3 ml of water. So whatever initially 3-4 days anybody is losing is the water and the glycogen, which is okay, which is equally important, because when we are talking about the knee joint, it is not only the fat weight what you have to decrease, any weight. So don't go with again ये तो water loss था, ये तो carbohydrate loss था. Initially you need a weight loss. It's not about fat loss, और वो fat loss हम लेंगे बाद में, पर हमको आपके knee joint को भी थोड़ा आराम देना है. Got it? तो अगर 1 किलो भी कम हुआ ना, वाटर लॉस भी और डायूरेटिक से भी, तो भी वो थोड़ा हार्ट को भी आराम मिलता है. हम डायूरेटिक क्यों देते हैं इन अ कार्डियक पेशेंट? सो हार्ट इज टेकन केयर ऑफ, हार्ट इज अ बिट नॉट ओवरबर्डन. सो हियर ऑल्सो इट इज नॉट ओवरबर्डन, सो इट्स ओके, फाइन. नाउ द लाइपोलाइसिस with all these deficiencies, we are in the state of stress, catecholamines are up, cortisol is coming up. So the catecholamine and cortisol, when they are working together along with the thyroid, what will it do? And growth hormone, what will it do? It start diverting the energy from the lipolytic pathway. Now from here the lipolysis will start taking the main role in the body. Now this lipolysis, and it is with any of the restriction. Okay. In lipolysis, what is happening? Now right away the hormone sensitive lipase of the adipocyte is activated more. Okay. And this hormone sensitive lipoprotein lipase, so what are the hormones which are responsible for it? I will again enumerate. So many, we remember it, we repeat it, we remember it. So glucagon, corticosteroid, ACTH, TSH, MSH, in the presence of good thyroid and good cortisol. So lipolysis start happening, and there is a breakdown of triglyceride in the fat cell. It is more called as a triacyl glycerol. In the fat cell, the same TG, they are the same actually, but it is called as triacyl glycerol. Otherwise, we very commonly say that triglyceride. Okay. So in the TG, it is a triacyl glycerol which is broken down in fatty acid and glycerol. And one thing we remember yesterday, why this broken fatty acid and glycerol not again combined back to make the triglyceride inside the fat cell is because the fat cell, the adipocyte, does not have one enzyme which is glycerol kinase, and because of that adipocyte itself cannot utilize the glycerol, and that is the mechanism nature has made. So fatty acid is out, glycerol is out. Now this glycerol goes for the gluconeogenic pathway to give glucose, and that's how this glycerol is sparing the protein. So protein body का बचना चालू हो गया. Done. And this fatty acid which is coming out now will be combined with the albumin. So fatty acid does not move free in the blood, usually it combines with the albumin for a better acceptance by the liver also, right? Now this fatty acid is combined with the albumin, and whatever the free fatty acid is readily available for the energy. Now this fatty acid is going to so most of the organs can use fatty acid even as a direct source of energy. Your heart, your spleen, your kidneys, they all can use fatty acid. Brain cannot use it directly. We have repeated this many times. Okay. Now this fatty acid go in the liver, and in the liver what is happening now? Fatty acid is having the option of what? Option of directly giving the energy. Again through the acetyl-CoA pathway, it goes to give, it goes in the, through the acetyl-CoA, it goes to the TCA cycle, and then it gives the energy. Fine? And fatty acids are high energy. Got it? A simple conversion of 2 carbons of fatty acid, 2 carbon of a fatty acid to acetyl-CoA gives you almost about 4 ATPs of energy, ATP. So 4 ATPs of energy are given at simple that one step. So think about any fatty acid which is 14 carbon, which is like a long chain fatty acid. So from 14 carbon, actually it is 16. So from 16 carbon, you usually get 7 acetyl-CoA molecule. Okay, and the 7 acetyl-CoA will give you 7 into 4, 28 ATPs only to give you the acetyl-CoA. And when this acetyl-CoA goes in the Krebs cycle, every acetyl-CoA is almost giving you 10 ATPs, maybe more than that. So 28 there and 10 here, 110 into 8, because one more is there. So 10 into 8 is 80 plus 28, 108 ATPs are produced with one palmitic acid. 108. 2 are used in the pathway. So total 106 ATPs you get from one palmitic acid oxidation. Clear? So either body can go in that pathway. But now, why the ketones are formed then? When body can form the energy by fatty acid, and heart can use the fatty acid, spleen can use the fatty acid, liver can use the fatty acid, kidneys can use the fatty acid, then what is the need to go in making the ketones from fatty acid? For the brain. RBC are using only glucose. So only for the brain this ketogenesis is happening. हो गया, अब अगला डीपी यही है, मेरा फ्लो चला जाता है, उनका टाइम चला जाता है उस चक्कर में. ओके, नाउ so this fatty acid is going in ketogenesis only to provide ketones to the brain, and also to other organs can also use the ketone, but primarily is for the brain. Clear हो गया? Obesity, whenever we are talking about obesity, three things usually. Now the same pathway which is giving the ketone, it is the same pathway which gives the cholesterol. The same pathway to certain extent, and then there is a diversion. This also, because as soon as we are talking about the low calorie diet, we are talking about the no cholesterol in the diet, we are talking about this. So how the cholesterol is coming in the body. So it is a de novo synthesis of the cholesterol. Inside the body, cholesterol is being synthesized. Now the same pathway from acetyl-CoA gives you HMG, HMG-CoA. So one enzyme, HMG-CoA synthase, works on acetyl-CoA, will give you HMG-CoA. Now this HMG-CoA is important. Now this HMG-CoA can go either towards the pathway of ketone synthesis or to the pathway of cholesterol synthesis. If there is too much of energy deficit outside, it will go for the pathway of ketone synthesis. Clear? If you are providing too much of energy from outside, even in the form of the high calorie, high fat keto diet, it will go to the pathway of cholesterol synthesis. Clear? So that is the problem with them when they start saying that eat as much as you want. Okay. Now, how? By HMG-CoA lyase, if works on this HMG-CoA, it will go to the ketone pathway. If HMG-CoA reductase works on this, it goes to the cholesterol pathway. And here comes the role of statin. If there is high cholesterol coming up, so don't hesitate to put statin to the patient. At least what you are doing, so you are seeing somebody who is, you are put on a low calorie, low carbohydrate or whatever, sir, low calorie restricted diet, right? And you are finding cholesterol to be on a higher side. I am talking about overall cholesterol to be on a higher side, right? So what will you do? Don't hesitate. Initially you give some statin. What will this statin do? This statin is going to inhibit the HMG-CoA reductase and divert the HMG-CoA to the ketone pathway. So more ketones would be available. But if you are doing it with a very high calorie, very high fat diet and give the statin, then the ketones would be absolutely out of control. Got it? And that's how, why when they say that calorie restriction with statin, even for the LDL control, they always say that, na, restrict your calories and add statin. It is not, they never say that eat whatever you want and keep on popping statin. No cardiologist say that. Clear हो गया? तो हमारा statin को लेकर के जो confusion है दूर हुआ. So statin डाल दिया. Obesity, whenever we are talking about obesity, three things usually. Now this same HMG-CoA lyase makes acetoacetate. Now this acetoacetate is available. Now this acetoacetate will be converting to beta hydroxybutyrate also. So one acetoacetate, one beta hydroxybutyrate. Now they can do their job either by interconversion or independently. So what they do, what these ketone bodies do, now they have the option, these ketone bodies, wherever they go. Now what option they have? Either they go on again on the energy producing pathway, or they go for the fatty acid synthesis. They can. In the brain they do like that way. So the ketone can again, means acetoacetate and beta hydroxybutyrate can again enter in the TCA cycle at the succinyl-CoA level. Okay, वहाँ गया तो it enter, तो हो गया Krebs cycle में, and Krebs cycle will give the final energy. Ketone job is done. Or if energy is not required, what will it do? If energy is not required and ketones are there by those heavy high fat diet, very heavy high fat, high calorie high fat diet, it is still available. So it is going again back to acetyl-CoA, and from acetyl-CoA it can either go to the glucose side or it can go to the fatty acid side. Now acetyl-CoA directly does not convert to glucose. It can convert to glucose only by the Krebs cycle, gluconeogenesis, otherwise no. So where it will go majorly then? The fatty acid synthesis. So more fatty acids are now again synthesized. जो break हुआ था, जो ज़रूरत नहीं है, फिर से synthesize होकर के आ गया. Clear? So this is about the acetyl-CoA, which is the any diet. Acetyl-CoA is our, हमारा दिमाग वही है acetyl-CoA की तरफ. Now with the very high calorie diet, if there is too much of fatty acid in the blood, what will happen? So this fatty acid will either try to go to the adipocyte to be stored over there, but we know that adipocyte will not be able to store the triglyceride because it cannot use the glycerol over there. So it will need some glucose to come inside the adipocyte, convert to glucose 6-phosphate, which convert to glycerol 3-phosphate, and adipocyte can utilize glycerol 3-phosphate. Okay, the fatty acid which is coming from the blood is utilizing some acetyl-CoA which is inside, and both of them making acyl-CoA. So acyl-CoA with glycerol 3-phosphate again make triacyl glycerol, which is the TG inside. So this is the pathway how the fat is going inside the adipocyte. Obesity, whenever we are talking about obesity, three things usually. But in the situation when there is no carbohydrate or zero glucose, then what would happen? Very little amount of glucose is available through whatever gluconeogenesis is possible, or otherwise body will start breaking down the protein. Body knows one thing. Body knows one thing, that too much of fatty acid in the blood is not good. This body will try to take that fatty acid out, either to the liver or to the adipocyte. But the fatty acid to be stored, fatty acid will need one thing. Fatty acid needs the glycerol, otherwise it cannot be stored. Clear? Glycerol we are not providing from outside, or whatever glycerol was coming, it has already been used for the glucose utilization of the brain, or means whatever small glucose brain is using, and the RBC. Now then, how this fatty acid will be stored? That is a big question. So whatever glycerol is not used, that is again going, but this glycerol directly cannot be used, so glucose is required. Okay, so either excess glycerol is converting in glucose and again giving that glucose to go in the pathway of glucose 6-phosphate and glycerol 3-phosphate to make triacyl glycerol inside the liver and inside the adipocyte, or it should come from somewhere else. From where it will come? I am talking about somebody high fat diet, high fat, high calorie diet. How it is, from where the body will now get the glycerol, whatever is now not available from any other side. So the option so either body allows the fatty acid to just move in the blood, or lot of fatty acid in the liver, which is going to bind lot of albumin. So there will be hypoproteinemia in these people, and you need albumin to carry lot of other things in the body. So there will be compromise on all those things. You need albumin to carry calcium, right? Albumin is a carrier protein. You need albumin to carry so many vital molecules or nutrients in the body, right? So albumin deficiency, not deficiency, but albumin is occupied by this free fatty acid. Body doesn't want it, doesn't want to have the free, albumin is binding the fatty acid for the free movement. Body doesn't want lot of free fatty acid accumulation if it is not required for the energy. वहाँ तक clear हो गया. Now अभी उसका एक limit है. So albumin is produced by what? Liver. So liver is getting overburdened. So there is a limit of it. Then what will body do? Body has to give the glycerol from somewhere, and from where it will come? Finally body will go in the protein degradation pathway, because then the protein breakdown would happen, amino acid will come, the gluconeogenic amino acid will start giving the glucose, and that glucose will give glucose 6-phosphate, which will give glycerol 3-phosphate, and finally this fatty acid will combine as acyl-CoA to the glycerol 3-phosphate inside the adipocyte, and the deposition will happen. But this deposition of fat will happen at the expense of the muscle protein. So this is the problem with the very high fat, high calorie diet. After certain time, what is going to happen? These people will again start accumulating the fat, and the glycerol of that fat will come from the from the glucose, which come from the gluconeogenesis, which will come from the protein breakdown. So this will be the fat deposition on the expense of the muscle, and there, that is the problem. So high calorie, high keto diet is not recommended. It should be a low calorie keto diet, because then you are managing the balance between the energy demand and energy utilization. Okay. Second problem with the high fat, high calorie, why I am stressing on this too much, because this is the talk of the town today. Everywhere being talked about, and every patient who comes to you will talk about it, right? So then comes is, what is the other flip side of it, is that if too much of fatty acid, liver is working more, liver is giving a lot of ketones, and the utilization of ketone is not happening, body does not need those ketones, so either it will, again that pathway of HMG-CoA will go to the cholesterol synthesis, and too much of cholesterol will come, so too much of LDL would come. You know what is the problem of that. Other is, if too much of ketones are there, body is not able to handle the ketone will remain in the blood. What would happen? There will be acidosis, and acidosis is life threatening, it's killing. Clear? Then for this extra ketone you need lot of water. Lot of water, if you are taking, lot of water means too much of water, then there are dilutional hyponatremia, dilutional electrolyte imbalances, which itself is detrimental for the body. Ketones have to be excreted out of the kidney because they are water soluble, so kidneys are also overloaded. So liver is overloaded to produce the ketone, kidneys are overloaded to excrete them out. दोनों जगह problem हो गया. Now acetone is one which cannot be utilized for energy, but it is going to give the bad breath and the bad smell in the urine. Okay, the extra cholesterol, because of that high fat diet which is coming, liver has to take it out. So where liver will excrete it out? In the bile. So bile will have lot of cholesterol, and the bile will be very, very thick, and a very thick bile will be gallstone. So the basic principle, again, maybe in these 2 days I have stressed a lot on this particular part, because this is what is going to, we all face it on day-to-day basis. When people come, and it's so difficult for us to sometimes explain them, don't do this. After 6 months you will come back to me with some or the other problem. Fine. So more and more deficit we are giving, energy is more, and energy requirement is maintained the same way. Fatty acids are going to get broken, so that the protein breakdown can be prevented, and that triglycerides are broken, the fatty acids are available, glycerol is available for the gluconeogenesis for the brain, glucose for the brain, fatty acids are giving ketones for the brain, fatty acids is consumed by other part of the body, other organs of the body, and body is getting enough energy. Obesity, whenever we are talking about obesity, 3 things usually, but after some time, and fat loss is happening, but after some time, what will happen? I wish it would have been so easy, everybody would be doing it, but after couple of weeks, or after 3 weeks, 4 weeks, whatever time, what is going to happen? Adipostat. Now you are losing the fat mass, so adipostat will start working. Now what will adipostat say, or what body goes in? Body says that I am losing the fat mass, which is a requirement of the body. We have to prevent it. Energy input is not happening. Body goes in an artificial hibernation mode. Human beings don't go in hibernation, right? So the animals who go in hibernation, what happens in them? What happens in the animals who go in hibernation? So before going in hibernation, they consume lot of fuel, right? And then they go in hibernation. During hibernation, they are utilizing that fuel, and then they come out. So that fuel utilization is the source of energy. Stored fuel is the source of energy during hibernation. And finally they come out, they start eating. Simple. Here human being is going in an artificial hibernation state of eating. Eating very less. But human beings are not equipped with all those mechanisms what those hibernating animals are. So after some time, body will go in a defense mode, so that weight is not lost again. Input is not happening. Body will try everything to decrease the output. And here again comes the role of the doctor. And how the output will decrease? So output will decrease. First is, whatever the voluntary activities a human being is doing will start getting diminished, because it all uses lot of energy. So exercise motivation will go down. In simple term, a person would not want to go out, person would not want to socialize, person would not want to go for parties, person would not like to go for meetings, person would not like to go for exercise, person would not like to go to watch movie, and everywhere the person will have an excuse. यार खाना तो कुछ नहीं है तो जाना क्यों, ऐसे ही बोलते हैं ना, खाना तो कुछ नहीं तो जाना क्यों. फिर आप सवाल पूछते हैं कि यार आप किसी की बर्थडे पर खाना खाने जाते हो, तो आंसर आता है नहीं, तो अभी क्यों कह रहे हो. When you go to anybody's birthday or anybody's wedding, the primary reason is to eat food. I am just asking general question.
Yes, of course.
No.
I mean to celebrate with the.
वो अंदर की बात है.
Okay.
But usually the primary reason is to celebrate. So primary reason is to celebrate. तो अगर फास्ट है उस दिन नहीं जाओगे आप विश करने के लिए. अभी रमादान के दिन किसी की शादी हो रही है और कोई है मुस्लिम हमारे दोस्त और वो आए तो आएंगे नहीं हमारे, हम रमादान पर है. अगर मान के चलो करवा चौथ वाले दिन किसी का हो रहा है, करवा चौथ इसीलिए बार बार बोल रहा हूँ कि अभी हो चुका है तो दिमाग में रहेगा महीने भर तक. सो या किसी का थर्सडे का फास्ट करता है, कोई मंडे का फास्ट करता है, तो नहीं जाएंगे आप, जाते हैं. सो द प्राइमरी रीज़न इज़ टू बी विद देम. दैट इज़ द रियल रीज़न, टू बी विद देम, टू ब्लेस देम, एंड देन एज अ पार्ट ऑफ दैट सेलिब्रेशन ईट एंड कम बैक. दैट इज़ द पार्ट. बट इफ़ यू आर रिस्ट्रिक्टिंग फूड, पहली चीज़ दिमाग में आती खाना तो है ही नहीं, तो मैं ये सवाल करता हूँ कि आशीर्वाद भी नहीं दोगे जाके. गो आउट यार, जाओ आशीर्वाद दे के आ जाओ, खाना घर से खा के चले जाओ. सो दैट्स हाउ द मोटिवेशन हैज़ टू हैपन. बट इफ़ यू सी दीज थिंग्स कम अप, उसको गिल्ट होता है बाद में जब आप ये सवाल करते हो, कहता है यार वाकई में मतलब क्या हम खाना खाने जाते थे उस टाइम पर. बट इट इज़ नॉट द ट्रूथ, राइट. सो दी स्मॉल एक्टिविटीज़ दे स्टार्ट avoiding, so that energy is not being utilized, energy is not being, you are not spending energy. And then sexual activity start going down. You don't want to spend energy in sexual activity. Those all the things which happen. Menstruation in a woman start getting delayed. Reason is very simple, so that there is no iron loss in the blood, there is no B12 loss in the blood, as simple as that. That prevent all of them. So all these things start happening through some or the other pathway. So पहला ये सब होता है, ये सब होता है तो क्या करेंगे. So either they will give up, and then again you are there, and then you tell that all these are the adaptive mechanism of your body so that you don't lose weight. Now you have two options. Either you start eating or you follow what I am telling you. If you start eating, you will come back to the same weight and nature will win. If you allow me to take care of you, I make sure that I will not let the nature win so soon or so early or so easily. And here then your target would be to fight. अब restriction of calorie तो आपने कर दिया, अब 2 हफ्ते के बाद में 3 हफ्ते में जब plateau आएगा तो क्या करोगे. Then you should know how this plateau is happening. So now you understood कि अभी जितना भी कैटाबॉलिज्म हो चुका वो हो चुका. अभी कैटाबॉलिक hormones will also go down. So anabolic hormone insulin had already gone down. Initially catabolic hormones were high. Now the catabolic hormone will start going down because body wants to preserve even the fat store and even the protein. Now catabolic hormones are going down, so energy is not available. Domain of aging. One domain of aging was energy availability and energy demand. So availability is not there. Initially for 2-3 weeks, availability was made by the change of the enzyme of the hormone system in the body. So catabolism was happening, so energy was still available. It was not going from outside, but inside it was available from your lipid stores and all. But after 2-3 weeks, this energy is also not available because body is now trying not to go lipolytic. Because fat is your cushion. Fat, you need fat. And body knows that 50 kg, 20% of fat should be there. This is nature knows. Now you are fighting with it. Got it? You go in the the patient goes in the defense mode. Lipolysis is not happening, or it slows down significantly to an extent where only the energy which is required to live is there. And how much energy anybody needs to live? It is not more than 16 calories per kg body weight per day. Actually less than that. So on that time, if the patient from say patient is 70 kg Now for 70 kg, 15 calories or 12 calories per kg body weight is how much? 800 calories is enough. Rest all very small amount of lipolysis is happening, some even gluconeogenesis start happening again, so that those vital organs are getting whatever is needed. So brain does not compromise, rest all the organs still compromise. Clear? And small you are giving from outside. So the new balance is there and the weight plateau. So what is happening? The catabolic hormones are also going down. Even the sex hormones are going down. Why the sex hormones are going down? Because everything is going towards the pathway of cortisol now. And even aldosterone. Because BP has to be maintained. Yes, aldosterone pathway also. Na? Cortisol goes, cholesterol goes towards the pathway of aldosterone. Cortisol goes towards the pathway of, cholesterol goes towards the pathway of cortisol. Cholesterol goes towards the pathway of aldosterone. And these pathways are testosterone pathway, DHEA pathway are compromised. Estrogen, progesterone pathways are compromised. And that's how they get the delayed menstruation, the woman, the low libido and all those things start happening. Okay? This is how nature is trying to create a new balance. And as soon as aldosterone is coming in a better range, BP is maintained. And the retention of fluid start happening in the body. So weight start getting, and body will still look for the glucose somewhere. So cravings will start happening. Got it? And now at this time, body doesn't want thyroid to be there. I mean to say the high thyroid to be there. So body start diminishing the thyroid activity, so catabolism is not happening. So glucagon activity going down, कैटकोलामाइन एक्टिविटी हैज़ टू गो डाउन, इसीलिए वो ठंडा पड़ जाता है फिर पेशेंट. मतलब ठंडा पड़ जाता का मतलब वो वाला ठंडा नहीं, पेशेंट ओके नहीं यार आई एम नॉट गोइंग, सो नो ड्राइव इज़ देयर, आई एम नॉट गोइंग. अब अभिनीत जी का फ़ोन आया कि चलो सर पार्टी करते हैं, नहीं यार नहीं आई एम नॉट गोइंग. राइट, सडनली यू सी समबडी चेंज्ड कम्प्लीटली, यू नो द पर्सनैलिटी इज चेंजिंग. कहते हैं ना, द पर्सन हु वॉज आउटिंग ऑल द टाइम इज नाउ अवॉइडिंग इट. नहीं यार आज मन नहीं कर रहा, कल चलते हैं, आज यहाँ नहीं करते, समथिंग लाइक दिस वे. सो वाई? बिकॉज दिस कैटेकोलामाइंस आर गोइंग डाउन. So glucagon going down, catecholamines going down, thyroid activity also start going down, and gonadotropin start going down. And because of this, now that person is in a new equilibrium. So initial few days, that individual is not very comfortable because of the change of behavior. But after some days, now he is comfortable or she is comfortable. So energy availability is enough to meet the energy demand of the body for the vital organs, and that individual is comfortable. छोटा मोटा अपने जो काम चल रहे हैं वो कर रहे हैं, एक्स्ट्रा एनर्जी कंजम्पशन वो नहीं कर रहा है. एंड हेयर इज द प्रॉब्लम, बिकॉज अब वो नए लेवल पर आ गया, लेकिन उसकी पर्सनैलिटी चेंज हो गई. दैट्स व्हाट आई वाज टेलिंग. व्हेन ओवरवेट, ही और शी वाज लाइक एवरीवेयर. आफ्टर लूजिंग वेट, नोवेयर, बिकॉज नाउ दे आर इन अ न्यू इक्विलिब्रियम, वेरी कंफर्टेबल विद दैट. उसके further no weight loss is also happening. They are in the equilibrium. But here, when the patients are coming to you, first is you don't want to change their personality also, right? They should be able to, do whatever recreational activity they do. But along with that, you have to even continue their weight loss. Otherwise, फिर से वहीं आके रुक जाएगा मामला. और but weight was their primary thing, and somewhere it will be hurting them कि मैं इतना कम खा रहा हूँ, फिर भी मेरा weight क्यों नहीं कम हो रहा है. Now, here comes the role of the pharmacotherapy. Obesity, whenever we are talking about obesity, three things usually. So what you are going to do here, we had seen the adaptation to starvation yesterday. देखा हमने? You remember that? Adaptation to starvation और adaptation to calorie restriction. तो endocrine adaptations क्या हो गया? तो एक तो हो गया energy expenditure कम करने का कोशिश किया. So they started restricting their physical activity so that the energy expenditure is minimized. And secondly, the menstrual irregularities or the delaying menses in a woman, again to conserve the energy. Decreasing sexual activity to conserve the energy. All these things are happening, and all these things are happening through the neurotransmitter and the endocrine control. So neuroendocrine, and here comes the role of neuroendocrine. So what you will try to do is, if for a short duration you can elevate the mood of the patient by atypical antidepressant without increasing the appetite. The bupropion, the topiramate, okay? You remember yesterday we spoke about them? You manage the hormone of the patient. Let it be DHEA, let it be growth hormone if needed, let it be testosterone whenever needed, just for that particular, to give that instinct, or to go in lipolysis, or a low dose of thyroid, or a T3 for a very short duration, till that plateau. So what nature diminished physiologically, it is not a pathological condition. These are physiological conditions, right? You are supplementing from outside and let the patient continue the other thing. So the plateau will break. Again, patient will come down. And then you withdraw. Again, after some time, there will be a plateau. Again you give, again you withdraw. Got it? So what in obesity management as a doctors we are doing? Calorie restriction, one part, physical activity motivation, other part, and whatever the adaptation happened in the body to maintain the weight even at a low calorie, we are blunting those adaptations by all these pathways.
So what is the duration of giving these?
Till the plateau is broken.
How do we know that?
Once the weight starts dropping down. What is a plateau exactly? So plateau is where the weight is maintained even at that low calorie, or even decreasing the calorie, even if you're decreasing it more, still the weight is maintained, and patient other activities are compromised, which patient and the spouse will automatically come and tell you. And that is the time when you have to now you know that all these things have happened in the body, which is actually good. That is the defense mechanism of the body. So there is one defense of the body. What? Initial defense was lipolysis, to provide the energy without compromising the activity. वो हो गया, उसमें हमारा बहुत ज़्यादा रोल नहीं हुआ. Our role was only our knowledge, which we told the patient. Right? Then there will be adaptation to calorie restriction to maintain the weight. तो आप देखिए दो adaptations हो रहे हैं. पहला adaptation is adaptation to decrease supply without compromising the demand. The anti-aging, one of the principle of aging, right? There lipolysis is happening, catecholamine stimulation and other hormone stimulation means the catabolic pathway. But if catabolism keep on happening, what will happen? The body will disintegrate, will die. So after some time, the body goes in a different defense mechanism where now again to make a new equilibrium for the energy availability and demand. So what body will do? Availability is not there from outside constantly, so it will try to decrease the demand. As soon as the demand goes down, by again I repeat, external activities, let it be your walking, your swimming, your recreational activities, your going to parties, going to play, sports, anything, sexual activity, or the physiological activities like menstruation and other thing, all of them are getting compromised. तो एक साइड वो कर दिया, तो उन्होंने क्या किया, पूरा का पूरा डिमांड कम कर दिया. तो फिर डिमांड रह क्या गया? डिमांड रह गया सिर्फ टू सर्वाइव एंड डू अ मिनिमम फिजिकल एक्टिविटीज व्हाट इज रिक्वायर्ड. एंड हाउ मच कैलोरीज यू नीड फॉर दैट? 800, 1000 maximum. So some is coming from the body, still some lipolysis is happening, or gluconeogenesis is happening, and other is still you are giving from your food. 800 calories तो आप फिर भी दे ही रहे हैं ना at some point of time. So there is a plateau. Now you know that anything which is happening in the body has to happen through the neuroendocrine pathway. The borderline high TSH in an obese individual is leptin induced, or this is a usual finding in an overweight individual, mainly leptin induced. When these people go on calorie restriction and lose weight, their TSH automatically comes down, which again is a defense mechanism, but here the defense mechanism is different because body does not want to go in the catabolic mode. But what the dietitian say that to the patient, that I have corrected your thyroid, but it was neither fault in the beginning nor it is fault today. It was actually corrected even that time, even today, but it is being misused commercially like anything. कि उस डॉक्टर ने थायराइड ठीक कर दिया, उस डॉक्टर ने हाइपोथायराइड ठीक कर दिया, हमने हाशिमोटोस ठीक कर दिया, हमने फलाना ठीक कर दिया. People keep on claiming like that way. No, it doesn't happen that way. These are the body defense mechanism, simple defense mechanism. Nobody treated it, right? So here now But now in this situation we are seeing TSH low. Low means lower than before. We see T3 on a lower side, lower than before. Not a true hypothyroidism. You see T4 on a lower side. But here you are seeing that patient is biochemically euthyroid. Range में है. TSH is normal, T3 is normal, T4. But patient is in plateau. We know that what is the pathway of the plateau. We know all this. We know thyroid axis, we know gonadal axis, we know the adrenal axis. If we give a low dose of thyroid to this individual for say 2 weeks time, very low dose, it can be 25 microgram, it can be 25 microgram of T3 maybe with 10 microgram, so 25 microgram of T4 with 10 microgram of T3. So what you are doing, one is you are increasing the catecholamine activity of the body and you are again going back. So the defense mechanism what body has given, that the thyroid activity has to be suppressed to protect the lipolysis, you have counteracted that one thing. Now patient is having low LH, low FSH, so you are giving a small dose of HCG. So you have even that axis you have taken care of. So stimulating the gonads. Patient is having very low libido. So to take care of that particular symptom, you give 1 dose of testosterone to a man or a DHEA to a woman. So at least that symptom is gone. Clear? Now all these things you are giving on a preclinical judgment. But definitely with the values in hand, because sometimes you have to stop them also. And as soon as we talk about the preclinical, is again it has always been our target as anti-aging, that we are targeting the preclinical and the subclinical cases. Now here it is physiological, which is induced by certain activity, but we as doctors have to counteract it for a shorter duration. The bigger problem happens with somebody on thyroid and never weans them off. So weaning is important. In 2 weeks you wean, and again you let the patient go ahead. Again the next plateau, again you do for a very short duration. Got it? So this is about how you are fighting with the plateau of the patient, and which is important. Preclinical of T3 and T4? No. See, what do you call as a subclinical level are the one which are the low normal. Anything which is low normal of a normal reference range can be considered as a subclinical. In obesity, when we are talking, again we have to understand one thing. Here we are not talking about treating a particular condition. Condition to wo hai hi nahi. Even if you don't treat it, patient is not going to have any problem, because that is a defense mechanism of the body. What you are trying to do is you are trying to fight the defense mechanism of the body. So you are going actually out of the box at that particular point of time. Like you give thyroid medication to somebody having urticaria. 2 weeks of thyroid supplementation to a euthyroid individual having urticaria sometimes gives a good result. Still you give it and you take it off. So these are the empirical indications for certain medication or every medication. Like you give Avil to somebody not feeling hungry. What do you say that? Okay, take one Avil first. Avil will increase the CPM, chlorpheniramine maleate, increases the appetite. So these are the off-label use. Not somebody not sleepy, not feeling sleepy, like in the colleges at least. What we used to take a CPM pill. रात को CPM खाया, मस्त सो गए, सुबह उठे भूख और लग रही है अच्छी खासी. ऐसे ही होता था कॉलेज में. We all have gone through this. So because we are not treating a particular condition, we are just using them for a very short duration to fight with this defense mechanism, for which we don't have much available today. And why should we have anything for that? Because that is a natural mechanism, and it is required by the body. It is like you are giving immunosuppression to a renal transplant patient. Why should you suppress the immunity? It is required, otherwise kidney transplantation will not be successful. So you have to give immunosuppression. So you are taking a very calculated risk at that point of time. So immunosuppression is a bigger risk in any patient compared to giving a very low dose of thyroid for a small time, or a single dose of testosterone, or a very low dose of HCG. They are very very safe in that way. If you are giving somebody 100 microgram of thyroid for no reason, it's a problem. 25 microgram of thyroid, why not? You can always go for it for a very, very short duration. But definitely if the patient is not able to tolerate it, like suddenly catecholamine releases are high and patient is having palpitations and all those things, then you have to stop it. So these are like every step, and therefore if anybody is for weight management with a doctor, has to be supervised like this way, and that makes a difference between us and whoever else is doing it, right? And so the basic principle is you lose the weight, you remain on that weight for some time, be there, just maintain it. That's what we spoke yesterday. The adipostat, if you have to maintain, you just lose, stay there, and here again. So when the plateau comes, so now there are two ways. One is, if the plateau has come early, plateau has come before what you had thought of, then your intervention will change. So at 10% I expect plateau. 10% of the body weight loss I expect plateau. Like 100 kg when comes to 90 should be a plateau. From 90 comes to 81 should be a plateau. These are like the biologically acceptable. So at 10% I am expecting, so I am telling my patient, okay, you are 100 kgs, we are doing it at between 88 to 90, you are going to get the plateau, don't worry about it. So you have conditioned the patient also. But now the plateau is coming at 95. Plateau is coming at 96. So you know that the defenses have happened a bit early. You are trying every bit. You are now here, then you are decreasing more calories initially. You are checking the compliance of the patient. If nothing is working, then you know that it is a neuroendocrine system which is at fault, which is working very good, not at fault. It is working very, very good. Take care of it. Got it? Now comes increasing the diet, this and decreasing. There is nothing when you talk about in terms of the objective evidence of losing the weight. Increasing the diet will not make anybody lose the weight. What will happen when we increase the food intake, the compliance again becomes better. Compliance becomes better because see, somebody who is restricted, अब now keto diet की तो हम बात ही नहीं करेंगे, वो तो पहले ही high calorie देते हैं. Now the keto diet, typical keto diet people are already giving a high calorie keto diet. What they are going to increase after that? So what they will maximum do, they will add up some other food material. So what they are playing with the mood of the patient, of the individual. You understood what I mean to say? There will not be advantage in terms of the weight management. But like you remember the last point of one of the presentation yesterday, that you have to manage the mood of the patient. That is very important. So if it is not something you need a weight loss in 2 months only because of any ABC reason, it's okay. It is not happening in 2 months. It can happen in 3 months. It can happen in 4 months. So in between, if you are becoming a bit flexible in giving some calories and all, like the way she was telling, if getting hypoglycemia or getting headache, or you were asking hypoglycemia, and you say, okay, that for few days you eat, and again come back. Remember that compensatory hyperphagia and hypophagia. So if there is a lot of restriction, body will try to eat more, and then if you give them to eat, maybe after that the compliance again becomes better, again their appetite is suppressed for some time and they can go for it. But the thing is, when we keep on doing it too many time, like giving food, again restricting giving, then results will not come that way. Because the escape phenomenon will always be there. Now here what we are looking at, point number 1 is why any individual is going for the weight management or losing the weight. What actually is the need? Need क्या है उसके पीछे? दूसरा कि at what stage that individual has already reached today because of whatever the attitude that individual had in the past. Up, your decision will be like that way. So to somebody you have to be very, very strict. So if somebody has lot of failures in the past, so out of your 100 people coming to you for weight management, 80 would be the one who have been to tens of places before you. And there are 100% chances that they will be failure with you. Why? Because they will try to do the way they want to do. And there you have to be very strict. 20% would be the new ones coming to you, they have never tried anything. There you may be a bit liberal. Now, somebody is getting a plateau, increasing the calorie intake or decreasing the calorie intake or doing other intervention. Now this is one question, 1, 2, 3. Increasing the calorie intake is doing nothing but simply breaking this defense mechanism of starvation, but not helping anything in terms of weight. Only the mood is good. Continuing the same calorie again is not helping in terms of the weight. Patient mood is also not that good, but not gaining weight. At least for some time, patient is going ahead. Decreasing the calorie will again increase his defense mechanism a lot, and maybe patient will complain a lot after that. So here comes the role of the intervention from outside, the medical intervention from outside. Understood? तीनों अलग अलग चीज़ें हो गई, therefore nothing is monotonous. तो यहाँ तक तो हम आ गए, तो अब हमको और भी वेट लॉस हमें चाहिए, डिजायर्ड हमको मिला नहीं, प्लेट्यू बहुत पहले आ गया, देन वी आर पुटिंग अप all these options what are available to us, which is there in your slides also. So we have what options we have? The neurotransmitter part, we have the atypical antidepressant for a very short duration, and which work even on the appetite and on the hormonal aspect. We can go with thyroid, we can go with HCG, we can go with a bit of testosterone. If we can go with DHEA, melatonin is definitely part and parcel of that. Right? So these options we have. Now, when we talk about HCG here, now again, so I jump to HCG from, अब ये एक ऐसी जगह जहाँ पर HCG सोच सकते हैं. HCG, human chorionic gonadotropin, has one beauty in itself. Human chorionic gonadotropin works on all the axes. It works on TSH axis. It is TSH, similar to TSH. It works on thyroid axis, TSH axis, it works on gonadal axis, it works on growth hormone axis. So if we don't want to give anything, so we have a HCG protocol in our hand. So which one thing is taking care of all these three things. It has got some endorphin, so mood is also taken care of. The commercially prepared HCGs are claimed to have some endorphins. So the mood is also taken care of. So HCG protocol can also, if somebody is well confident about doing an HCG protocol, it can be done. If HCG protocol is not done, other things can be added. A bupron, a topiramate at that point of time. HCG protocol में तो प्लेटू आने में टाइम लगेगा. Okay. यहाँ तो आपको प्लेटू आ गया तो आपने ये सब कुछ ऐड कर दिया, आपने ब्यूप्रोन ऐड कर दिया, आपने टोपिरामेट, ज़रूरत पड़ने पर टोपिरामेट ऐड कर दिया, ज़रूरत पड़ने पर आपने थोड़ा ग्रोथ हार्मोन ऐड कर दिया, ज़रूरत पड़ने पर DHE ऐड कर दिया, मेलेटोनिन तो पार्ट एंड पार्सल हो गया, ज़रूरत पड़ा आपको तो आपने whatever extra is needed you have added. It is completely at the discretion of the physician. No very fixed protocol in that, right? And definitely under monitoring and supervision. Doses are very, very low, so we don't expect the life-threatening side effects in that. And the plateau will break, again the weight is going down, you are decreasing a bit more calories, stopping all these whatever you have used. Again, wait for the next plateau. Whenever the plateau comes, you can use them again, and that's how you can reach to a desired weight whenever interventions are done, whenever needed. Now the question comes is when the patient reaches to the desired level. Obesity, whenever we are talking about obesity, three things usually. Patient पहुंच गया अपने desired weight पर. Now what will you do? Very simple. My aim is very clear. For next 6 weeks to 3 months, I am going to monitor the patient for not gaining weight and even not losing weight. So my focus would be no weight gain, no weight loss. तो पहली चीज़ मेरे दिमाग में ये आ गई कि no calorie deficit to be given to this particular individual. Again, we go back to the same calculation what we did yesterday. 80 kg individual has become 60 kg now by giving the calorie deficit. Now for this 60 kg, how much energy is required to survive? So into 1200 calories. And patient has changed his lifestyle and everything, and even exercising now. You were so motivating and so good in your approach. So 300 calories you added with that also. Benefit you give to the patient. 1500 calories now you can give to that 60 kg man or woman. Where is the problem? What you are managing here is, you are telling, one thing you have taught the patient. As soon as you go on a very high carbohydrate diet, high glucose intake and the trans fat intake, then you are again going to go in the weight gain pathway. It is as simple. अब वो बोलेगा, is lipogenesis happening in me? The answer would be yes, you will be having lipogenesis, but because we are giving you a very balanced diet for yourself like any other healthy individual, so you are going to have both lipogenesis and lipolysis in a balanced form. So can I eat like that other person who is so fit, so called so fit? So answer would be no, because you have been obese at one point of time. So one thing is very clear, your body probably favors lipogenesis more than lipolysis. So anytime that opportunity will come, it will again go back in the lipogenesis mode. So don't try to go overboard. We have increased your calories, but the calories will again be restricted in carbohydrate. And then yesterday we spoke about it, 120 gram of glucose what brain would be needing. So we have to give the total carbohydrate intake of the body should definitely be much lesser than 120 grams, because ब्रेन को नहीं देना है हमें. तब तक जब तक अगर ब्रेन को एक बार 120 ग्राम मिल गया तो फिर वो ब्रेन कुछ और कराएगा ही नहीं. मेरे घर में पैसा आ रहा है तो मुझे नहीं फ़र्क पड़ रहा किसको क्या चल रहा है. इट इज़ समथिंग लाइक दैट वे. सो in any diet what we are making after that for the patient is the carbohydrate is still under control, under check. And then comes that, okay, दोबारा हुआ तो मेरा weight gain, doesn't matter, it's a chronic remitting relapsing disease. We are there. तो सर मैं यही कर लूँ? No, there would be other protocols too. And जब when you are talking about 30, 40, 50 kgs weight loss, I am talking about people of 120 kgs, 130 kgs, and your target is 70 kg, then a single protocol will not work to reach to a desired level. So what you are doing is, again, it's not only about the quantity, it's even the quality of food. You are keeping changing your protocol. So patient initially say you started somebody on a HCG diet, example. So patient knows that okay, something is being done medically, right? Motivated hai, medical ho gaya. Agli bar, now for the next round of the weight loss, so patient lost 12 kgs, 15 kgs and done. Now you maintain that weight for say couple of months for the adipostat to be reset. Then again from that, say 120 se patient aa gaya 105. From the 105 now you have to bring the patient to say 90 kgs. Now you don't need to again restart on HCG, maybe you may not. You say that okay, now let me do the keto, typical keto diet. Let it be there, a low calorie, high fat diet. Now patient is very happy because during the HCG diet, patient was not on fat, it was zero fat. Now here patient is getting all fat, so patient is happy, right? Again patient loses, but the prime principle is the same, the low calorie, restriction of calorie as per that weight. Okay, but still patient is eating a bit more because वहाँ पर restriction ज़्यादा था. Clear हो गया? Now here again patient loses say 10 kg, 12 kg, 15. Okay, let's maintain it. अभी 95 पर हैं आप या 90 पर हैं, let's maintain from here. Again maintain for 2 months at 90. Again patient is coming. Now you have again option. You can again either restart the HCG protocol, or you definitely don't want to go for a high fat keto again because already done before. Brain also knows it. A repeated brain can respond very fast, right? Now you can go with overall low calorie diet. So low fat, low carbohydrate, even low protein. Doing nothing because now the target is only 10 kgs from there. So you have reached. And once you have reached the final weight, now you say that okay, 2 months we will maintain it. I will keep on introducing small things in your diet. वहाँ पहुँचने के बाद में once the patient maintains the weight without even losing the weight, you should never say the patient don't gain. You should say the patient remain here, don't even lose. Obesity, whenever we are talking about obesity, 3 things usually you are thinking, and then comes your choice of food. अभी सब बंगाली is coming to you, बंगाली eating रसगुल्ला every day. तो आपने एक बार पहले का रसगुल्ला बंद करना है तो पहले तो बंगाली या तो आपको छोड़ के चले जाएंगे, क्यों डॉक्टर साहब? कि भाई सब कुछ है, रसगुल्ला नहीं छोड़ सकते. But you know, because you know a typical food habit of everybody. So I am from Mathura. So if I become overweight, or if anybody from Mathura comes to me who is overweight, I know one thing, कि पेड़ा तो उतना नहीं, पेड़ा बाहर के लोग खाते हैं. तो these people are eating lot of kachori and jalebi in the morning. Because Mathura का वो staple breakfast है, which is available outside. Like Bhopal, they have poha and what? Jalebi. Poha and jalebi. Like in Maharashtra, we have our vada pav, misal and all those things. उतना हमको सबको पता होता है कि regional diets क्या हैं, और हम सबसे पहले जो उस पर हिट कर देते हैं. जैसे ही वो बंद होता है बॉडी को, तो खाली कैलोरीज का प्रॉब्लम नहीं है, इट इज़ परसीव्ड एज द स्ट्रेस बाय द बॉडी, एंड देन यू गेट ऑल दिस स्ट्रेस रेस्पॉन्स एंड यू गो इन द मोड ऑफ लाइपोलाइसिस। सो स्टेपल को चेंज करना है, ट्रेंड को चेंज करना है, कैलोरीज को कम करना है, क्वांटिटी को कम करना है, एंड दिस इज द जनरल वे, एंड इन बिटवीन एज अ डॉक्टर वॉट एवर इज नीडेड वी हैव टू डू। क्लियर? दिस इज अबाउट द ओबेसिटी मैनेजमेंट. Obesity, whenever we are talking about obesity, three things usually. Then comes the intermittent fasting. Intermittent fasting, where various regime are there. It has always been there in our Hindu mythology, so Hindu culture. We have always been doing it. So every week. So now it is said that, which is in Harrison itself, once a week to 2 days a week of fasting is considered to be good, not for weight management, good for longevity. Now losing weight and longevity are not again synonymous, दो अलग चीज़ हैं. ओके, सो वंस अ डे कंप्लीट फास्टिंग 24 आवर्स. अपनी तरह नहीं मंगलवार का व्रत किया हनुमान जी का और शाम को लेकर के बूंदी लेके बैठ गए. यही होता है ना अपने यहाँ. कितने लोग हैं बजरंगबली का भक्त करते हैं? मैं एक टाइम पे करता था. तो व्रत करके शाम को बूंदी खा रहे हैं भर के, तो वो नहीं चलेगा. सो फास्टिंग शुड बी 24 आवर्स. इफ आई स्टार्ट फास्टिंग टुडे, it should go till tomorrow. Okay, once a day, once a week to twice a week, means once in every 3 days. This is what is the only water. So this is what can be done. Third is, eat whatever you want for couple of days and go for complete fast for a day. Then after that you won't be able. So when you eat for 2 days, definitely you go in compensatory hypophagia. So you are fasting, and the third day you eat moderate. Then you are eating mild, and then again you are going for 2 days of whatever you want to eat. Again 2 days of fast, and that's how you keep on going, rotating. How much time? This was a very good article which came about a week or 10, or maybe about a month back. So here. It is for not for the weight loss actually. They claim it is for the weight loss. It is for the weight management. Now here again you are playing with the adipose. तो आपने क्या किया? 2 दिन जम के खाया. थर्ड डे वैसे भी भूख नहीं लगेगी आपको. So you are fasting. You are बहुत लोग जो सोमवार का व्रत करते हैं श्रावण में, तो संडे दबा के खाते हैं ताकि मंडे को बाय आफ्टरनून तो भूख लगती नहीं है, राइट. एंड देन उसके बाद में चलता है. फिर वो सारा कचरा कर देते हैं, खाली साबूदाना खाते हैं. सो अगेन ऑल द कार्बोहाइड्रेट कमिंग बैक. बट दैट वाज अ कॉन्सेप्ट एट दैट टाइम ना, ईट साबूदाना, सो इट्स ऑल कार्बोहाइड्रेट, सो रिजर्व विल बी कमिंग बैक, बिकॉज द व्रत वॉज नॉट देयर फॉर वेट लॉस, इट वॉज देयर फॉर लॉन्जेविटी. प्लीज अंडरस्टैंड, वेट लॉस इज नॉट लॉन्जेविटी. यहीं हम कन्फ्यूज हो जाते हैं हर बार. तो आई एम डिफाइनिंग इट. सो आपने 2 दिन जो मन में वो खाया, थर्ड डे फास्ट किया, फोर्थ डे थोड़ा बहुत जितना खा पाए खाया, चौथे दिन आपने फिर से थोड़ा मॉडरेट नॉर्मल जो आप पहले खाते थे खाया, और फिर से 2 दिन आपने जम के खाया, फिर से फास्ट कर लिया. या आपको समझ में आया? या आपने मॉडरेट के बाद 1 दिन का फास्ट कर लिया, फिर आपने 2 दिन जम के खा लिया और फिर एक फास्ट कर लिया. सो दैट्स हाउ दीज आर ऑल. देयर इज़ नो टिपिकल गाइडलाइंस ऑन दैट. ये कोई प्रिस्क्रिप्शन नहीं है. दिस इज यू डिसाइड बाई योर सेल्फ. आप देखो कि आपके पेशेंट, या आप खुद, या मैं खुद, या हमारे मरीज़, हमारे फैमिली में हमारी क्या रिस्पॉन्सिबिलिटीज़ हैं, हम किस दिन भूखे रह सकते हैं, किस दिन नहीं रह सकते हैं, ऑल दोज थिंग, एंड विद दैट यू डिसाइड. बट नथिंग शुड बी मेड लाइक अ क्लेम फॉर इट विल मेक समबडी लूज वेट. वेट लॉस का एक ही तरीका है जो सबसे अच्छा है, वो है कि कैलोरी रिस्ट्रिक्शन हमें करना ही करना है. कैलोरी रिस्ट्रिक्शन विद प्रीडोमिनेटली कार्बोहाइड्रेट रिस्ट्रिक्शन इज आवर प्राइमरी एम. सो वी हैव टू टेक द पेशेंट टुवर्ड्स द पाथवे ऑफ कीटो जेनेसिस. ये हमारा टारगेट है. बात ख़त्म हो गई. और जब हम ओबेसिटी को डील कर रहे हैं तो हमको फार्मेकोथेरेपी जब भी ज़रूरत है इस्तेमाल करने में हिचकना नहीं है, बिकॉज वी आर डॉक्टर्स. वी नो व्हेन टू स्टार्ट एंड वी नो व्हेन टू स्टॉप. प्लेट्यू विल कम, प्लेट्यू शुड कम. इफ प्लेट्यू इज नॉट कमिंग, पेशेंट इज हैविंग सम प्रॉब्लम इनसाइड, शुड बी इवेल्युएटेड थॉरोली. कोई बीमारी तो नहीं है, कोई टीबी कैंसर लेके तो नहीं बैठा हुआ पेशेंट अंदर. सर इट विल बी अ प्रॉब्लम. प्लेट्यू नहीं आया अगर 10% वेट लॉस पर, सचेत हो जाइए, समथिंग इज रॉन्ग. ओके, प्लेट्यू आ रहा है, despite of decreasing the calorie intake, mood is also not good, then you know what you have to do. You have to supplement with a short course of whatever things required, right? The neurotransmitter control and the hormonal control, the domains of aging, and then let the plateau break, and again you withdraw those medication, and again it goes smoothly till the next plateau come. And when you attain a final weight, 2 months, 3 months, follow the patient, and not to lose weight, not to gain and not to lose. And again patient wants to lose further, you can change the protocol. In terms of, if it was initially low calorie, high fat, you can make it low calorie, low fat, high protein, then you can make it low calorie, low fat, low protein. Choice is completely yours. Carbohydrate in any way going to be restricted. Done.